secondary hyperparathyroidism comes in, right? Tell us about that.
Exactly. In secondary HPT, the parathyroid glands are actually working correctly in a way. They're pumping out more PTH because they're responding to another problem in the body, usually low calcium or high phosphate. By far the most common cause is chronic kidney disease, CKD. It's often called CKD mineral and bone disorder, or CKD-MBD. What happens is failing kidneys can't get rid of phosphate properly, so phosphate levels go up, hyperphosphatemia. High phosphate actually binds to calcium, lowering the free calcium levels in the blood.
So low calcium triggers the parathyroids?
Precisely. Low calcium is the strongest signal for the parathyroids to make more PTH. Another big cause of secondary HPT is simple vitamin D deficiency. Not enough vitamin D means you can't absorb calcium well from your diet, leading to low calcium again. Less commonly, conditions that cause malabsorption in the gut can also lead to low calcium and secondary HPT.
So the mechanism is different. The glands are trying to compensate.
Right. The low calcium, and in CKD the high phosphate too, directly stimulate the glands. Plus, in CKD, the damaged kidneys are also less able to activate vitamin D, that 1025-year form we mentioned. So that makes the calcium absorption problem even worse. It becomes this cycle, low calcium, high PTH, which then affects the bones trying to get more calcium.
Okay, so how do the symptoms differ then between primary and secondary?
Well, because the underlying issue is often kidney disease or severe deficiency, the symptoms can be a bit different.
You often see more severe bone pain and a higher risk of fractures. This is part of what's called renal osteodystrophy bone disease, specifically related to kidney failure.
Intense itching, pruritus, is really common, often linked to the high phosphate levels in CKD. Vasculocalcifications, calcium depositing in blood vessels is a major concern, again, often driven by high phosphate. And then you still get general symptoms like muscle weakness and fatigue, similar to primary in some ways.
And the lab tests must look different too.
Critically different. In secondary HPT, yes, the PTH is high. But, and this is key, the calcium level is usually low or maybe normal. It's not high like in primary. That tells you the PTH is responding appropriately to low calcium. If CKD is the cause, phosphate levels will likely be high, and vitamin D levels are often low.
Any specific signs on imaging for secondary?
Yeah, X-rays can sometimes show changes related to the renal osteodystrophy. Things like superior resorption, where bone looks like it's being eaten away right under the surface layer, especially in the fingers. And sometimes the rugger jersey spine, the vertebrae, get this striped appearance on X-ray. It looks like, well, a rugby jersey.
Interesting. So treatment for secondary must be totally different then. You're not usually taking out the glands.
Exactly. The treatment for secondary HPT is all about fixing the underlying cause. If it's CKD, you focus on managing the kidney disease. That means using phosphate binders, drugs like sevelamer or calcium acetate, to lower phosphate levels in the gut. Giving vitamin D supplements is crucial, either the storage form, cholecalciferol, or the active form, calcitriol, depending on the situation. Cinacalcet, the drug we mentioned for primary, can also be used in secondary HPT if the PTH stays very high despite managing phosphate and vitamin D. It helps lower the PTH drive. And of course, for severe CKD, dialysis is necessary.